The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. All right, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Finally finished up the Neph Madness stuff. Didn't do as well as I hoped in the competition, but that's okay. It's all about learning, right? That's what losers always say. But no, for real, this all is about learning about current topics in nephrology. And it's such a cool thing. It's a neat activity. It's actually fun in a nerdy sort of way. And it gives me a lot of content to make podcasts out of. So I'm a fan. I'll definitely be participating every year as long as they keep doing it. And it's worth 8 hours of CME. So if you haven't tried it yet, I encourage you to give it a shot next year. Jump in and compete. Get some free CME and learn some stuff. In this episode, I'm going to actually go back through all of the regions, all of the information in Neph Madness, and just summarize it all. So if you didn't get a chance to participate, or if you want to hear an overview of the specific information that was presented, that's what I'm doing today. Before I get started, just a quick plug for an event that's happening this week. This will come out on Monday, April 28th. Friday, May 2nd, 2025 is the Shells and Tails Dinner, which is a fundraiser for the Community Free Clinic of Decatur, Morgan County, where I do a little bit of volunteer work. This is a very cool event that happens at the Witt House in Hartselle, which is a really beautiful venue. It's this huge spread with catfish and shrimp, sides and desserts and drinks and all the things. And then a band performs. This year the entertainment is Bishop Black. I will put a link to buy tickets if you're interested in coming. Again, that's Friday, May 2nd, 2025, starts at 6 p.m. So hope to see you there. All right, here we go. Specific regions of Neph Madness 2025. First region, resistant hypertension. Two competitors are renal denervation and novel drugs for hypertension. Selection committee member for this region was Dr. Jody from Penn. She's been a guest on the Curbsiders podcast several times. She's really cool. The writer for this region was Dr. Stephanie Torres Rodriguez from UT Southwestern. They have what they call a podcast crawl, so they do an episode of various podcasts about these different regions. So this particular region was discussed on the Curbsiders, episode number 474. Hey, if anyone from Neph Madness is listening, if you're looking for another podcast to add to your crawl, I could suggest one. Anyway, so hypertension, second leading cause of kidney failure in the United States. Globally, it's considered the number one modifiable risk factor for any sort of cardiovascular disease. And they estimate that only about 21% of people diagnosed with hypertension actually have it controlled. I'm trying to relate that back to my patient population. I feel like we're pretty good at least getting people on blood pressure medicine if they clearly have hypertension. I tend to not get too worked up about the 130s, 140s over 80s kind of range. I normally let people float in that neighborhood. So hopefully in my patient panel, it would be at least a little better than 21%. So anyway, resistant hypertension is defined as your blood pressure still not controlled, even if you're on 3 or 4 different classes of medication. Or if it is controlled, but you're having to take 4 different medications, then we still consider that resistant. And the caveat here is that this is in an appropriate situation with appropriate goals and a compliant patient, that sort of thing. If there's a situation where the goal for treatment is just wrong, if you're not measuring the blood pressure correctly, if somebody has white coat hypertension, or if they're not taking their medication, any kind of situation like that is referred to as pseudo-resistant hypertension, meaning we just don't have the right information or we don't have the right goals. So the first specific topic is renal denervation. This is really an old idea. It came about like at least 150 years ago. We know that sympathetic nervous system innervation of the kidney is a contributor to hypertension. The juxtaglomerular cells have beta receptors that cause renin release and starts the whole RAS pathway, renin-angiotensin-aldosterone system. There are alpha receptors on proximal tubular cells that affect sodium and hydrogen exchange, which causes more retention of sodium. And sympathetic stimulation causes vasoconstriction of both afferent and efferent arterioles, which serves to lower the GFR. And all these things lead to higher blood pressure. There is a feedback loop from the afferent renal nerves to the central nervous system that has an effect on cardiovascular regulation and sympathetic outflow. So under normal circumstances, you have these baroreceptors in the kidneys, right, that respond to the stretching of the arteries that should be able to turn down the sympathetic activity. But in hypertension, that normal feedback loop is disrupted. So you get an inappropriate amount of sympathetic activity in the kidney. This is actually called neurogenic hypertension. And down the line, that's going to affect systemic vascular resistance and cardiac output. So the thought with this has been that if you can surgically interrupt the nervous pathways that affect all this, then you should be able to stop this neurogenic hypertension. The first time somebody tried a procedure to do this was 100 years ago, 1925. And that particular procedure was the preferred treatment for resistant hypertension for like 20 years after that. Unfortunately, there was a very high rate of surgical mortality associated with that, and the patients would have all these bad side effects from the surgery, including low blood pressure, impotence, and bowel incontinence. So in the 1950s, when blood pressure medication came along, they kind of bailed out on the surgical practice and ended up going more toward medication, which of course is what we mostly do now. But the idea of surgically intervening to correct neurogenic hypertension has persisted.
Starting in 2007, they've been using catheter ablation to accomplish this renal denervation.
And maybe there's some benefit to that. There were some questionable studies that looked at that. A better study called Simplicity HTN3 came out in 2014 that showed very little benefit of this ablation procedure versus a sham procedure. So only 2 millimeters of mercury difference between the patients that actually had an ablation and the ones that had a fake ablation. But nevertheless, this did progress, and there are currently 2 FDA-approved methods of doing ablation procedures for this. One of them involves radiofrequency and the other involves ultrasound. There's another one that's being developed now that involves injecting dehydrated alcohol into the area. And so overall, with all these different methods, they've shown about as much efficacy as being on one single blood pressure medicine as far as how well they actually control blood pressure. So is it really worth going through an invasive procedure and taking all the risks that involves for so little benefit? And also, we are talking about nerves here, right? So just like the radiofrequency ablation they do for chronic back pain people, those nerves eventually are going to regenerate. So this may be a thing that whatever effect it has is not going to be as strong as time goes on. I guess it would be helpful if you have somebody that's just not going to take blood pressure medicine and just can't control their blood pressure any other way. I guess you could see some benefit there. I remember this is all about kidney disease, so we don't really even have data about people who already have CKD and how they would respond to this procedure. And of course, it's expensive. It's about a $20,000 cost associated with this. It's sort of hard to imagine that the value of this over time would even justify the cost, much less the risks to the patient. I did actually listen to this Curbsiders podcast. The rest of these things, I have not listened to the podcast associated with the region. But on this one, Dr. Cohen was a big fan of the renal denervation. She said, "Oh yeah, people ask me about this in my clinic all the time. People are really interested in this." And I don't think that would be the case in my clinic. I have a hard enough time getting people to take statins and get flu shots. It's hard for me to imagine that a lot of people would be up for this unless there was some huge benefit. Second topic in the region is novel drugs for hypertension. So there are some new medications that target a substance called endothelin-1. This is a substance that's produced by the vascular endothelium and plays a role in resistant hypertension. If you listen to my episode about the Huntsville Hospital cardiology update from this year, Dr. Cavo actually mentioned this specifically in the talk he gave. So this substance promotes vasoconstriction. It's actually the most potent vasoconstrictor in the body that we know of, as well as vascular remodeling and hypertrophy over time. It causes more production of growth factors and inflammatory mediators that contribute to hypertension, as well as atherosclerosis, fibrosis, and vascular damage. Production of this substance is upregulated in severe hypertension, obesity, and CKD. So there's this new medicine called bosentan. That's a generic name. It's actually already approved, but only for pulmonary hypertension, that targets this endothelin-1 specifically. It has a lot of side effects. It may be kind of hard on the liver. There's a second one called aprocitentan. That's also a generic name, and it's also already FDA approved. This is a dual endothelin receptor antagonist. It has pretty decent blood pressure lowering capability and has fewer side effects than the bosentan. It seems to work pretty well in people that have CKD, as well as older people and people with proteinuria. It has a long half-life, 44 hours. For whatever reason, it seems to work better at night than during the day. Another new class of drugs are the aldosterone synthase inhibitors. There's a thing called the aldosterone escape effect, where the levels of angiotensin II and aldosterone will bounce back up, rebound. Oh, there's a basketball word, rebound, after initially being suppressed with other medications, so like ACE inhibitors, ARBs. So these aldosterone synthase inhibitors work to bypass that effect. They actually will stop the production of aldosterone. And in general, it's really hard to do that without also blocking cortisol, but somehow these medications are able to do that. The 2 examples around currently are baxdrostat and lorundrostat. I don't know if those 2 are actually available yet or FDA approved yet. And then there's another class in the pipeline called small interfering RNA, or siRNA. These work by reducing the production of angiotensinogen in the liver. They bind to a receptor in the liver called the acyloglycoprotein receptor, and that causes reduced levels of messenger RNA in the liver that lead to the production of angiotensinogen. And this is actually a sub-Q injection that's given either every 3 months or every 6 months. That's what they've been doing in trials. The one medication, which is currently still investigational, is called zilebesiran. And the other medication they threw into this novel drug category is semaglutide. Of course, these GLP-1 medicines seem to work for everything, so why not blood pressure? Over time, people on semaglutide do generally see a reduction of blood pressure and often are able to discontinue some of their blood pressure medication. Obviously, the thought would be that that's due to weight loss that it causes. So in this region, my pick was for novel drugs, which was the correct choice. My thinking on that was just that renal denervation has been around for 150 years and hasn't really caught on in that amount of time. And also, it seems like there's a pretty small benefit for the risks you have to take to go through an invasive procedure like that. Obviously, with the new medications, there'll be some cost issues that will be a barrier to getting people on those. The one that affects messenger RNA specifically, with all the problems we've had with bad information around the COVID vaccines, I imagine that mRNA thing is going to scare a bunch of people into not being interested in taking that. But I see the drugs as being definitely more practical overall than the surgical procedure. So that was my choice. Next region, disaster nephrology, kidney care and natural disasters versus kidney care and conflicts. The selection committee member for this region is Dr. Mehmet Sever from the Istanbul School of Medicine. The writer is Dr. Rasha Roslan from Duke. This was discussed on the Life as a Nephrology Professional podcast episode that came out on March 13th, 2025. There's a big correlation between disasters of all types and kidney injuries. They recognized that initially after World War I. At that time, there was a Japanese dermatologist who was training in a German pathology lab. It's probably a lot darker story underneath that benign-sounding statement. But this dermatologist figured out that at least some of the battlefield deaths were due to kidney failure because of rhabdomyolysis. They did a study after the Blitz happened in London during World War II and recognized this very specific form of oliguric renal impairment related to crush injuries. And around that time, you actually have the, quote, artificial kidney, unquote, introduced, and they were able to use that to treat some of these AKIs. There was an event back in 1988 in Armenia where there was this huge earthquake, and a lot of people died from kidney failure due to crush injuries, primarily because they didn't have enough dialysis available to treat all these folks. And that particular incident led to the creation of what's called the Renal Disaster Relief Task Force by the International Society of Nephrology, and also a new term came out from that event, which is renal disaster. And so since then, there's been this whole field of disaster nephrology that has evolved. Most recently, the American Society of Nephrology, the European Renal Association, and the International Society of Nephrology all came together to create this kidney support initiative to help coordinate global responses to renal disasters. See, we can still get along with the rest of the world in some situations. So this region is separated into natural disasters and conflicts. Under natural disasters, acute kidney injury is actually the second leading cause of death after earthquakes, the first just being direct trauma. I would not have guessed that. After hurricanes, we see that patients on dialysis have a higher mortality rate compared to other groups. I wasn't quite clear reading the information whether that means people who were already on dialysis prior to the hurricane or people who got on dialysis after the hurricane. I assume it means people who were already on dialysis. It just makes sense, right? If the dialysis centers are destroyed or can't function for whatever reason, then people can't get dialysis. So there are several mechanisms for acute kidney injury after disasters. If you're trapped under rubble for a long time, you get really dehydrated. That leads to a pre-renal acute kidney injury. If you lose a lot of blood, go into hypovolemic shock, then that's a mechanism for pre-renal AKI. If you have pelvic trauma that causes an obstruction of the urinary tract, then that can lead to post-renal AKI. And then you can have intrarenal AKI, both ischemic and toxic varieties, because you have situations where people are in shock for prolonged periods of time, where sepsis is setting up, where people are using different nephrotoxic agents and having transfusion reactions. There's nothing different about managing any of these situations during a disaster. So this whole field of disaster nephrology is really focused on dealing with the consequences of crush injuries specifically. So when a person has a crush injury, you get this hypovolemia that's related to compartment syndrome. That leads to rhabdomyolysis. When the muscle cells are damaged, they release myoglobin, and that big dump of myoglobin is what ends up harming the kidneys. You get these intratubular casts that form in the kidneys from that. So that, combined with hypoperfusion of the kidneys, combined with direct toxicity to the kidneys, can lead to an acute tubular injury. The hallmark of rhabdo is elevated CK, creatine kinase. Of course, during a disaster situation, a lot of times you're having to just rely on clinical signs to diagnose rhabdo. So those are primarily decreased urine output with a crushed injury and then dark-colored looking urine, Coca-Cola urine, as I've always just heard it described. So the earlier you can start fluid resuscitation for these people, the better. So even if the victim is still trapped, if you can get an IV in and start giving them IV fluid aggressively, you can prevent some of these AKIs. The recommendation is isotonic saline at 1 liter an hour, which will later be switched to hypotonic alkaline solution without any potassium, of course. And then you have to just monitor the urine output closely. If they do have to be dialyzed, the preferred method is intermittent hemodialysis rather than peritoneal dialysis or CRRT. That's continuous renal replacement therapy, just because the intermittent hemodialysis is better for relieving hyperkalemia. It's also just logistically preferable because you can do more patients with it than the other two methods. Back to what I was saying earlier about dialysis centers not being available after disasters, a lot of those centers don't have backup generators, which seems a little crazy. I would assume that the dialysis machines themselves have battery backups, but that seems pretty flippin' ridiculous if you're running a dialysis center and have no way to keep doing dialysis if the power goes out, right? Another population of people that can be affected by disasters are people waiting for transplants, or the transplant centers themselves, of course. And then you have people who have already had transplants who have to have their anti-rejection medication. And those people on anti-rejection medication are more susceptible to communicable disease, which of course may be a problem during a prolonged disaster sort of situation. So a lot of ways that kidneys can be affected by this sort of thing that I wouldn't have necessarily thought about specifically. So when we're talking about preparation for natural disasters, of course, people who have to get dialysis and dialysis centers should have some sort of plan in place for what happens if they can't operate as usual. People who do hemodialysis need to have a plan for other centers they can go to and have their information ready to take with them. If there is warning of an impending disaster, maybe altering the dialysis schedule to do it early could make it possible for the patient to not have dialysis again until after the disaster is over, if it's only a few days. Of course, people who do peritoneal dialysis at home tend to be a little bit better prepared for these situations. They really just have to have a stockpile of stuff so they can keep doing what they normally do. Some people that do home dialysis use a machine called a cycler, and so those people need to know how to do manual exchanges if they don't have that machine available or if they can't use it. During a disaster, it's possible to make arrangements for evacuation of dialysis patients through various organizations that would do that. In my experience, I assume that would be through FEMA and AMR, who are in charge of ambulance operations during those big disasters. And then it would be great if dialysis centers had some temporary way of doing dialysis, which means they need generators and water tankers. It takes a lot of water to run a dialysis center, or actual mobile units that are dedicated to doing dialysis. I'm picturing something like the blood donation bus, only for dialysis. Talking about conflicts, obviously wars tend to last longer than natural disasters, and wars can last a really long time. And those tend to happen in areas that are already kind of struggling, right? That already have kind of shaky infrastructure in place. So not the best circumstances to begin with, usually. Of course, during a war, a conflict, transportation and supply chains may be disrupted either intentionally or unintentionally. You may have a lot of population displacement, more so than during a natural disaster, right? Refugees fleeing a particular area en masse. And you're probably going to have fewer medical professionals around. Causes of AKI specific to conflicts like this. Of course, you can still have the same situation with crush injuries from rhabdomyolysis if people are trapped under rubble after buildings are bombed. You can have hemorrhage from trauma, from gunshot wounds. You can get an infectious disease that spreads around. You can be exposed to noxious gases or other toxic agents that damage the kidneys. Or you could potentially receive a blood transfusion with the wrong type of blood. I'm guessing they're referring to like field hospitals, temporary facilities set up like that. You can see how it'd be easier to make a mistake like that. People with chronic kidney disease, of course, they're going to be affected by not being able to get medications, not being able to see healthcare providers, or not being able to even obtain appropriate food. Of course, patients on dialysis ought to be evacuated somewhere where they can get the dialysis they need. It may be necessary to have people do dialysis less frequently than they normally would based on resources, locations, etc. If you don't have surgeons around to put in grafts or fistulas, you may have to rely more on indwelling catheters and leave those in for longer than they really should be used to do dialysis. Of course, people doing peritoneal dialysis at home may not be able to get the supplies they need, and there might be increased risk of infection if they're not in their normal housing situation. So my pick in this region was for natural disasters, which was the correct pick. The reason I chose that is just that I feel like natural disasters are probably going to be more problematic for more people on balance than war, conflict. It seems like there are more natural disasters happening. I'm saying that's related to climate change. And also, I think warfare is kind of moving away from the traditional large-scale battlefield kind of warfare. I think it's more precision, targeted attacks with drones and things like that that don't involve sending huge numbers of troops to places. And also more cyber warfare. I feel like that's kind of the warfare of the future, is just trying to disrupt your enemy's infrastructure by hacking into computer systems and that sort of thing. The next region is genetics, the two competitors being genetics and FSGS versus genetic counseling. Selection committee member for this region is Dr. Jordan Nestor from Columbia.
The writer is Dr. Matthew Gross from Hopkins.
This was discussed on the GN in 10 podcast, episode number 8. So FSGS stands for focal segmental glomerulosclerosis. I totally didn't have to look that up to know what it stood for. This is a pattern of kidney injury that involves scarring of some of the glomeruli. Primary FSGS is suspected to be caused by some as yet undiscovered permeability factor that is toxic to the podocytes. Those are the little epithelial cells that line the outer surface of the glomerulus. And of course, secondary FSGS develops as a maladaptive response to something, whether that's diabetes, a viral infection, toxic drugs, whatever. And there's also hereditary FSGS, which is just a genetic abnormality that affects whatever part of the glomerulus it affects. There's a specific set of gene mutations which causes APOL1 associated FSGS. APOL1 is apolipoprotein 1. Specifically, it has a role in innate immunity against the parasite that causes African sleeping sickness, which is Trypanosoma brucei. Overall, the incidence of FSGS is increasing. About 35% of people who have kidney biopsies for proteinuric kidney disease end up having FSGS. The genetic component here is important because they're working on developing medications that target very specific things based on which genetic mutation is actually causing the problem. So making a very specific genetic diagnosis of this is becoming more important. So if you do genetic testing to find out very specifically what the problem is, you can avoid giving people treatments that aren't really necessary. So like maybe it's not necessary to blast somebody with a big immunosuppressive medication when there's just one little thing we could address instead. And you could potentially know other things that might be helpful for specific genotypes. So for instance, CoQ10 is helpful for some specific genotypes of this. Doing the genetic testing could help prevent unnecessary biopsies, right? If you find the genetic mutation without having to do a biopsy, that's great. Genetic testing could also reveal other extrarenal problems that might otherwise go unnoticed. Genetic information could be helpful when making decisions about kidney transplant. And of course, it also suggests whether or not a person's family members are at risk of having the same thing. Under the genetic counseling section, by the way, this was, I think, the only section that was actually written in the theme of Neph Madness this year, which was a Back to the Future kind of vibe. So kudos to the writers for doing that in this section. With CKD overall, there could be a genetic cause in about 37% of those patients. And obviously, just like what we just covered, if you know the underlying genetic cause, that can help you guide your treatment and also predict the success of a transplant. There are different testing modalities. This part's really way over my head. I'm getting out over my skis talking about genetic testing, but you have what's called Sangar screening. You have curated gene panels, aka next generation sequencing. These are really faster, cheaper ways of doing it. And you can isolate and amplify the sequences of interest in parallel, so you can kind of do multiple things at the same time. There's whole exome sequencing. This looks at only about 1 or 2% of the entire genome, but that is where you find most of the disease-causing mutations. There's whole genome sequencing, and then there's chromosomal microarray testing, which is where you use high-resolution imaging to detect chromosomal abnormalities. Issues, problems with genetic testing. There's some question about how to obtain consent for this. Given the long-reaching implications of genetic testing results, is it even possible to really obtain informed consent? We don't know. There's a cost issue, of course. These tests may not be covered by insurance. There's a risk of discrimination against someone based on their genetic makeup. There is a law about this. It's called the Genetic Information Non-Discrimination Act, or GINA, which does provide some protection to people in some circumstances, but it doesn't apply to disability insurance, life insurance, long-term care insurance, and it also doesn't apply to the military, where they could potentially use genetic information to decide what someone's going to do in the military or determine whether or not they're eligible for benefits. Of course, like any other testing, there's a potential for incidental findings, and that might mean abnormalities that we know cause disease or abnormalities that we are not really sure whether they're significant or not. Of course, there's a psychological impact on the patient of knowing that you have these genetic mutations that are going to lead to something down the road. A parent may feel guilty about passing something on to their children, or a family might disagree about what path to take and what to do about the situation. And then there's the whole question of whether or not we test children and what kind of impact that is going to have. Usually, this is not done unless the result would have some kind of immediate clinical implication. So, a lot of things to think about there, a lot of ethical and legal considerations. My choice in this region was genetics and FSGS, which was correct. My reasoning on that was that I think genetics is like the future of medicine. I hope that everything over time is going to become more personalized, more specific, more targeted, just based on genetic information. I think that's where we're headed. But the point of this competition is to think about what's going to most affect the field of nephrology in the next 5 years. So when you're talking about FSGS specifically, this is a very specific problem. We already have specific medications that can be used based on the results of the genetic testing, so that's why I picked that one. The next region is CAR T for autoimmune disease versus CAR T side effects. I guess this would have been my biggest error for the whole competition because I chose the wrong one. I chose the incorrect one in this region, and that one that I ruled out is the one that was the champion for the whole thing. So in the post-mortem of my performance on Neph Madness this year, this is the big major screw-up. Selection committee member for this region is Dr. Jeffrey Sparks from Brigham and Women's Hospital and Harvard Medical School. Writer is Dr. Yara Muawad from University of Texas at Houston. This was discussed on the Room Madness podcast, Season 5, Episode 11, that came out on March 12th, 2025. CAR T stands for Chimeric Antigen Receptors T-cell therapy. So this is used for treating blood cancers that are refractory to other therapies. And it may also be helpful for autoimmune disease. The idea for this came about back in the 1980s. The idea is to engineer a person's T cells to recognize cancer cells and attack those. T lymphocytes play a role in cell-mediated immunity. They operate by recognizing peptide antigens that are presented by major histocompatibility complexes on the surface of cells. The first FDA-approved treatment for this came about in 2017. It was to treat a B-cell precursor of ALL, which is acute lymphoblastic leukemia or acute lymphocytic leukemia. Looking at it for treatment of autoimmune disease, we know that B cells play a predominant role in a lot of autoimmune disease. So since they were able to use it successfully to treat a B cell precursor of cancer, they started looking at it for autoimmune stuff as well. We know that you can use monoclonal antibodies to target B cells. We've seen that work well for rheumatoid arthritis, as well as granulomatosis with polyangiitis and microscopic polyangiitis. In 2019, they used CAR T to treat a patient with lymphoma and noticed that it also cured the patient's long-standing antiphospholipid syndrome. There is some evidence for CAR T benefit in lupus, idiopathic inflammatory myositis, and systemic sclerosis. So the bottom line here is that this is a really promising avenue that could lead to using other types of immune cells in similar ways for different conditions. And this could definitely lead to very personalized treatment regimens over time because you would be engineering these T cells based on the biopsy of an individual patient's organ. So you'd be able to tailor those therapies very specifically to an individual person. Super cool stuff. The next section is about side effects of CAR T. In the short term, you get this cytokine release syndrome secondary to activating all these different T cells. That can cause a full spectrum from mild symptoms all the way up to multi-organ failure and death. Most cancer patients who are treated with CAR T are going to experience some form of this, up to like 70 to 90%. So almost all patients are going to experience some form of this. And it seems like that's probably the case with autoimmune patients too, based on the data we have so far. The severe variant of this, they actually call it CRS, cytokine release syndrome, seems to be the word they used is infrequent. I would really like to know how infrequent before you start engineering my T cells. There's also a situation called immune cell-associated neurotoxicity syndrome. That has something to do with cytokines, but we don't quite understand the mechanism of that yet. They think it may be related to hypophosphatemia somehow. This causes confusion, aphasia, seizures, and coma. Regarding kidneys specifically, both of these issues, the cytokine release syndrome and the immune cell-associated neurotoxicity syndrome, can cause acute kidney injury. Long-term side effects include cytopenias and hypogammaglobulinemias, which would then lead to higher risk of infection. We have seen that after CAR T treatment, B cell and IgG depletion specifically can persist for years after. And then there's an issue of malignancy. Messing with the T cells can cause T cell cancer.
although it seems so far like the risk of this is not even as high as people who are treated with chemotherapy or radiation currently. So I went conservative in this region. I chose side effects. My thinking was just that data on this is so limited. I would hope that more studies and clinical trials about adverse effects would be done before this becomes ready for prime time, at least in the next 5 years. But I do hope it works. It sounds super duper cool. The next region is hemodialysis. The two competitors are hemodiafiltration versus incremental dialysis. Selection committee member for this region is Dr. Mariana Murea from Wake Forest. The writer is Dr. Manasi Bapat from Kaiser Permanente in California. This was discussed on the Freely Filtered podcast, episode number 38, that came out on March 12th, 2025. So when we typically think of dialysis, we think of people going to a hemodialysis center and spending 4 hours of their life there. They have to do it 3 times a week. And in general, that type of dialysis is really focused more on numbers than it is focused on a person's quality of life, right? Nephrologists do a lot of number work to calculate the parameters for each person's dialysis. This has been around for quite a while. Dialysis came about back in 1943, and even in all that time, we haven't made the outcomes a whole lot better as far as quality of life, having more hospitalizations, and 5-year mortality rate. The outcomes still just kind of suck for dialysis patients. So hemodiafiltration, or HDF, has been around since the 70s. One limitation of hemodialysis is that it's not able to filter out very large molecules. So the hemodiafiltration combines techniques of diffusion and convection to remove both small and very large molecules. Some specific examples of things that are caused by larger molecules that can't be filtered out in hemodialysis that could potentially be filtered out with HDF are carpal tunnel syndrome, left ventricular hypertrophy, and endothelial dysfunction, although I guess there's still some question about really how helpful that is or how true that is. One meta-analysis of 4 different randomized control trials showed that there's a pretty big mortality benefit of HDF compared to dialysis. They found a 14% improvement in all-cause mortality and a 23% improvement in cardiovascular mortality compared to hemodialysis. And long-term follow-up of the patients who participated in those randomized controlled trials did show that there may be a cardioprotective effect of the HDF compared to regular dialysis. The CONVINCE trial that came out in 2023 showed kind of the same information regarding all-cause mortality, but it didn't show the same cardiovascular benefit. So again, some question about that still. There's a situation where this hemodiafiltration is considered a device that has to be approved by the FDA because it generates its own replacement fluid rather than using pre-made bags of replacement fluid. So as of now, it's not really available in the United States because it's not approved yet. Another benefit of the HDF compared to dialysis is that the volume of replacement fluid that the patient actually gets is way more than with traditional hemodialysis. This article doesn't really go into why that benefits somebody. I don't really know off the top of my head, so I'm not going to say anything else about it. And then there's also a question about how cost-effective this would be compared to traditional hemodialysis. Under incremental dialysis, this is also known as incremental start hemodialysis. This is where, rather than just following a cookie-cutter plan for starting somebody on hemodialysis, you adjust the frequency and duration of their treatments based on their specific clinical situation and biology. Usually, when they start somebody on dialysis, they don't really consider their residual kidney function or their specific situation. They just kind of use a standard prescription. So the idea here is to take into account the remaining kidney function that a specific patient does have and try to tailor the dialysis treatment to take that into account. Obviously, that's harder to figure out, and it takes more adjustment over time than just slapping them on a standard dialysis regimen. They started doing this back in the 60s, but it kind of faded out over time in favor of just doing more standardized regimens. I assume just because of convenience and efficiency. Also, unfortunately, there's the situation where if people aren't getting as much dialysis, that means that dialysis centers are not making as much money. So the industry in general might not get behind this idea of incremental start. There's this theory that doing incremental start dialysis might actually help preserve some of the residual kidney function. You see this process where the nephrons that are still functioning, that are still alive, actually will try to take up the slack and do more work. But if you're getting hemodialysis too frequently, it kind of stops that process. So it's actually bad for residual kidney function over time. But that idea really has not been proven yet. So basically, we need more data to support the benefit of doing incremental dialysis versus one size fits all. I mean, it makes sense that it would be better to consider a patient's individual situation, but maybe the benefit is not as clear as we would think. So I picked incremental dialysis as the winner for this region, which was correct. I didn't really like either one of these choices. The incremental dialysis idea has already been around for a long time and it hasn't caught on. The other situation, the HDF, requires new technology, a lot of money, new FDA approval, etc. You could do incremental dialysis now. It just takes the time and effort to do it. And there's no way that the other technology is going to come around and change the whole situation in the next 5 years. Also, it occurred to me as a primary care person, I'm very jealous of nephrology getting to check a box and do something in a standardized way when I feel like I have to reinvent the wheel for every single patient to find the right answer for that particular patient. The next region is greenhouse. Competitors are tubular toxins versus oxalate offenders. The selection committee member for this region is Dr. Linda Audishu from the University of California at San Diego's Skaggs School of Pharmacy. Writers are Dr. Rachel Kahn from VCU and Dr. Ethan Downs from VCU. This was discussed on the Poison Lab podcast, episode number 36, that came out on March 1st. So this is all about herbal alternative kind of medications. It's really hard for us to know what to tell patients about those things. Historically, Western medicine, allopathic medicine in general, has had a pretty negative attitude about that kind of stuff. So that sometimes leads patients to be hesitant to even tell us that they're taking this stuff in the first place. We obviously don't get a lot of training on those things. These are not regulated, so we don't even really know what's in them sometimes. And they're not studied like actual medications, so we don't have data about how they work and their side effects and blah, blah, blah. There's a website from the NIH that I was not aware of. It's called the National Center for Complementary and Integrative Health. They have a resource called NatMed Pro that you can use to get legitimate information about all this stuff. It's a subscription. If you want to use the NatMed Pro, it's like $182 a year. In general, it's a good idea to encourage people to use supplements that have the USP seal on them. That's US Pharmacopoeia. That's a voluntary program that manufacturers can participate in to help ensure safety and quality in the products that they're selling. And then there's another seal called GMP, which stands for Good Manufacturing Practices. If you see that seal, that means that the process that they use to manufacture the supplement is FDA approved, even if the supplement itself is not. So under tubular toxins, some of these herbal medications can be harmful to the kidneys. In Africa in particular, this kind of situation accounts for 35% of acute kidney injuries. It's estimated that about 8% of people with CKD are probably taking some kind of herbal thing that they ought to avoid. I'll put a link in the show notes to a National Kidney Foundation article about this specifically. I'll also put a link to that National Center for Complementary and Integrative Health. Herbal medications can directly harm the kidney or they can interfere with other medications. It's kind of hard to know what the exact mechanisms of harm to the kidneys are, but most commonly the injury patterns we see are acute tubular necrosis and tubulopathy, both proximal and distal. They gave several specific examples. The first is called aristolochia, also known as Fang-G. They recognized back in the 60s that this could cause nephropathy. Researchers actually used this to mimic CKD in rodents. So they used this to give mice kidney disease in order to do whatever research about CKD. It really, really messes up the kidneys. If you get aristocolic acid nephropathy, most of the time that progresses to end-stage renal disease. And there's also a strong connection to urothelial cancer. Another example is called glycyrrhiza, aka licorice root. This has metabolites that block an enzyme that leads to uninhibited cortisol action. So that's going to cause hypertension and hypokalemia. It is also capable of directly causing toxicity to the tubule. Another example is senna, as in that senna, the laxative. It can cause an accumulation of anthraquinone glycosides in the kidney that leads to acute tubular necrosis and then indirectly to hypokalemia and volume depletion. Another example is Taxus celebica, aka Chinese yew. It contains a flavonoid that's been implicated in acute kidney injury and also hemolysis. Some other specific offenders we know of that cause the same kind of issue are Euphorbia paralyus, which is used as a diuretic, Cape aloes, which are used for constipation, and Calolepsis laureola, which is used for, quote, various conditions, unquote. The last specific example here is Colchium autumnale, of which colchicine is a derivative that can actually be mistaken in the wild for garlic. And if you eat that instead of garlic, it is poisonous to you. They mentioned that another potential mechanism of harm of these supplements in general is that sometimes heavy metals can be used during their production. And if those get in your body, they can cause kidney issues as well. Under oxalate offenders, Oxalate is an organic acid that plants make to protect themselves from different ions like calcium, which is found in high salinity groundwater. It also protects plants against infection and herbivores because it causes a thing called oxalate toxicosis in livestock that might eat the plants. It has no known nutritional value in humans. It reduces the absorption of calcium, iron, and magnesium. In a typical American diet, we usually take in about 200 milligrams per day. We might absorb 5 or 10% of that, and the rest of it is pooped out. The oxalate that is absorbed gets excreted by the kidneys. You absorb less oxalate if you eat more calcium. Calcium actually binds with the oxalate in the gut and keeps it from being absorbed. So if you're eating things that have higher oxalate to calcium ratio, that can be more of a problem. People who've had Roux-en-Y gastric bypasses actually absorb more oxalate compared to people who haven't. I'm sure we've all heard of oxalate or calcium oxalate kidney stones, so that's one of the main problems with hyperoxaluria. It can also cause oxalate nephropathy and maybe lead to progression of CKD. In those cases, the calcium oxalate crystals actually just deposit into the kidney and directly cause damage to the tissue. They listed some things that have high oxalate levels. Those include spinach, nuts and seeds like almonds, cashews, and peanuts, grains including wheat bran and oats, rhubarb stalks, fruits including kiwi, guava, and star fruit, and beets. Turns out vitamin C actually gets metabolized to oxalate, so if you're taking in a lot of vitamin C, that can also cause the same issue with oxalate nephropathy and kidney stones. And there really aren't any specific guidelines for treating diet-induced oxalate nephropathy. So recommendations here would be to avoid high oxalate foods, make sure you're getting enough calcium, increase fluid intake to prevent too much oxalate from building up in the kidneys. Potassium citrate can help the kidneys get rid of oxalate because it increases the urinary solubility of oxalate. So that's one thing we always hear about preventing kidney stones is take citrate. There are products that contain Oxalobacter formigenes and oxalate decarboxylase, both of which enhance the intestinal metabolism of oxalate. And then lanthanum carbonate also binds oxalate in the gut. Both hemodialysis and peritoneal dialysis can remove oxalate, so that's good to know. My pick here was tubular toxins, which is correct. I'm forever fascinated at how many patients who are scared of taking actual medicine will load up on all this herbal stuff that, comes from a gas station or a health food store or whatever. I generally don't poo-poo those things. To me, if there's no obvious harm and they help, great. If you feel like you're getting some benefit, fantastic. I always tell people if it's not costing you a ton of money and you feel like it's helping you, I'm fine with it generally. I don't know that we would know if they were causing harm. I don't know that a lot of people would take that into account when they're thinking about some medical condition. But I think it's probably on all of us to do a better job of knowing about these things, knowing what they're taking and how it could affect them. It's like a whole other area of medicine that I think a lot of us just don't know anything about. I don't personally take a ton of supplements. I do like a multivitamin and that's it. My thought being just in case there's something I'm not getting in my crappy diet. But yeah, that seems like the Wild West to me, the whole situation with supplements and herbal things. The next region is obesity and kidney transplant. The competitors are obesity in donors versus obesity in recipients. The selection committee members for this region are Dr. Shui Ling Levea from University of Texas Southwestern Medical Center and Dr. Babak Orandi from NYU Langone. Writers are Dr. Alyssa Ice from Vanderbilt and Dr. Trevor Stevens from Vanderbilt. Dr. Stevens is an alum of the University of South Alabama, which is also my alma mater. Go Jags. This was discussed on the Nephron Segment podcast, episode 16, that came out on March 10th. Obviously, lots of people are obese, which is defined as having a BMI greater than 30, and that includes a lot of people who are going to get kidney transplants. Weight gain after kidney transplant is a thing. About 30% of transplant recipients are going to gain more than 10% of their body weight during the first year after their transplant. And obesity does have implications for outcomes after kidney transplant. Obesity can actually disqualify someone from being a kidney donor. Depending on the center, there's usually a cutoff of BMI of 30 to 35 for somebody to be a kidney donor. And, just in medicine in general, we kind of just think of obesity as a bad thing. We think it increases risks for a lot of bad things. There aren't very many disease processes you read about that don't list obesity as a risk factor or a contributing factor or whatever. The expert commentary that was associated with this region mentioned a thing called obesity paradox for dialysis patients, where dialysis patients who are larger tend to have a survival advantage. That doesn't seem to be true after transplants. I've heard about that in cardiology too. They talk about the obesity paradox, where if somebody is super huge and you'd think their coronary arteries would be completely obstructed, most of the time they really don't have obstructed coronary arteries, which is telling, right? You call it a paradox because everybody understands we think this is bad. This should be bad, right? Why is it not bad? So anyway, obesity in donors. Of course, you have to balance a person's desire to donate a kidney with whether or not it's actually safe for them to do that. It seems like we actually don't have a ton of data that show an increased risk of having problems or adverse outcomes for obese donors. There are kind of mixed results in the research about that. We really need more research to kind of nail down firm recommendations about how much weight somebody should lose before donating a kidney and how long they should try to keep that off in order to mitigate any increased risk from obesity. Under obesity in recipients, it's pretty common for kidney transplant recipients to be defined as obese, up to about 30% of people who receive kidneys. Obese people, again, that's BMI greater than 30, are about twice as likely to develop some kind of complication with wound healing after transplant surgery. Some of the immunosuppressant medications that recipients have to take, specifically steroids and calcineurin inhibitors, will increase their risk of developing diabetes, which is already increased if you're obese. Over time, outcomes for the actual grafts are better for non-obese patients. There's a situation where some transplant recipients are actually scared to exercise because they're afraid that it will damage their new kidney, which is not true, by the way. It's fine to exercise once you're cleared to do that after surgery. And recipients also may avoid eating more fruit because of the high potassium content in the interest of not damaging the kidney, which is a thing. We should still not be scared to encourage these patients to eat more fruits and vegetables in their diet, just like anybody else. My pick for this region was recipients, which was incorrect. I have a lot of bias in this area. Anything about obesity, just because I've always been overweight, it's just a sensitive subject for me. I have a lot of personal bias anytime I'm reading anything about obesity. I think there's probably a lot of anti-fat bias in medical research, just like there's a lot of racial bias. But I still generally believe it's not great to be obese. And I see that people get better when they lose weight, for sure. So I don't have any beef with that general thought. With this particular region, I felt like it's kind of more on the recipients to take care of the kidney after they get it. Evidently, that was not the thinking of the Blue Ribbon panel. The last region is minimal change disease. The competitors are pathogenesis and diagnosis versus relapse. The selection committee member for this region is Dr. Susan Samuel from BC Children's Hospital in Vancouver. Writers are Dr. Mallory Downey from McGill University and Dr. Robert Mayette from the Children's Hospital of Eastern Ontario Research Institute. This was discussed on the Kidney Chronicles podcast, episode number 36, that came out on March 9th. So minimal change disease results in damage to podocytes, which are those epithelial cells around the glomerulus that I mentioned earlier. The clinical manifestations are proteinuria, hypoalbuminemia, and edema, also known as nephrotic syndrome. And the pathogenesis of this really is not known. We don't find any signs of inflammation in the kidneys with minimal change disease, but it does respond to steroids, which is weird. It usually starts after it's triggered by something that activates the immune system, whether that's an infection or a vaccine, an allergy, some kind of systemic autoimmune issue or cancer. For a long time, they thought it was mediated by T cells, but now they think it's more of a B cell and autoantibody kind of situation. Anti-nephrin antibodies may be important in this. Those antibodies target the junctions between those podocytes. Nephrin is an important component of these. Specifically, those are called slit diaphragms. So you could actually use those antibodies to diagnose and monitor effectiveness of treatment in some subset of minimal change disease cases. And the discovery of those antibodies and kind of having a better understanding about the origin of minimal change disease, of course, could lead to better treatments for it. Under relapse of minimal change disease occur in about 2/3 of adults that have it. Even more in kids, in children that have disease that's responsive to steroids, about 80% will relapse at some point. Up to half of those kids will have frequent relapses or become dependent on steroids. And by the way, whether or not minimal change disease responds to steroids is a really important prognostic indicator, but also determines how it's classified. There's a new risk score that's come about that uses several different urine biomarkers to try to predict who's going to become resistant to steroid treatment over time. It doesn't seem like that risk score is reliable enough to figure out the etiology of a specific patient's minimal change disease, but it might be helpful to use in conjunction with new discoveries that might come about in the future. It seems like we have not yet discovered a particular biomarker that can tell us about either initial responsiveness to steroids or relapse over time. There are some non-steroidal treatments for this, including cyclophosphamide, tacrolimus, levomethol, rituximab, and mycophenolate. Those can all be useful in adults. We don't have a lot of data about those for kids yet. So my pick here was pathogenesis and diagnosis, which was correct. It seems like the knowledge that maybe this is a B cell thing and kind of going in that direction is a pretty significant development and a big step to understanding this thing that we really don't know a lot about. So hopefully more research in this area will keep shedding light on what causes it and lead to better diagnosis and treatment over time. Okay, so that's all the specific information that was presented in Neph Madness 2025. Really cool stuff. It's a neat way to learn about these new things or things that I don't actually deal with in practice from day to day. I do want to recognize the members of the Blue Ribbon panel for Neph Madness who vote on the winners. This year was Dr. Roger Rodby from Rush, Dr. Deidre Cruz from Hopkins, Dr. Kurt Campbell from Penn, Dr. Samira Farouk from Mount Sinai, Dr. Tom Oates from the Royal London Hospital, Dr. Meredith Atkinson from Hopkins, Dr. Linis Alcantara Quiroga from the General Hospital of Mexico in Mexico City. She was actually the highest scoring fellow in last year's Neph Madness competition. Dr. Claudia Sweeney from Children's Health Ireland. She was the highest scoring attending in last year's Neph Madness competition. And David Rush, who is a platinum-selling recording artist and a former in-center dialysis patient. He does a lot of work as an advocate for home hemodialysis. He's the host of the Wins Only Lifestyle podcast and serves on a bunch of boards for kidney-related things. The executive team for Neph Madness this year, these are the game makers who designed the whole thing. Dr. Matthew Sparks from Duke, Dr. Anna Bergner from Vanderbilt, Dr. Anna Vinikova from VCU, Dr. Elena Cervantes from Hopkins, Dr. Jeffrey Cott from Stony Brook Medicine in Long Island, Dr. Anna Catalina Alvarez Elias from the Renal Research Institute, Dr. Daya Wagispak from UT Health in Houston, and Dr. Krithika Mohan from Cytocare Hospitals in Bangalore. Apologies for all the names I likely butchered there. If you haven't claimed your CME credit yet, you can still do that until the end of May. It's a pretty easy process. You just go on the Neph Madness website and you have to create an account on this thing called Case Hippo. You go through and do a big long survey, and then you get your certificate for 8 hours of CME. I appreciate y'all following along with my progress. I've been trying to do little update videos and shorts, all of which can be found on YouTube as well as the regular podcast platforms. I notice that when I post a video podcast on Spotify, it does not get posted as a video on YouTube. So sorry about that. A couple of times I went back and posted the video separately on YouTube, and a couple of times I just decided not to worry about it. So maybe I can streamline that process a little bit for next year. We'll get back to our ABC series. For the next podcast, I'm thinking about doing cirrhosis for C, so look forward to that. Special thanks, as always, to our Patreon supporters. Thanks to you for listening. I hope you have a great week, and I will talk to you later.
All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.